Very important from a pediatric endocrine perspective, because a lot of what we do is related to these three organs, the hypothalamus, pituitary and the gonads. So basically what we see, we have this 12-year-old girl who is menarchal, presented with a height of 138 centimeters and bone age is 13.5, pretty advanced. GnRH analogs were given, but what do you expect the growth to increase? How much would have increased? Already 13.5 years. So maybe after 1 year, she was 2 centimeters only. So 1 to 2 centimeters, 3 centimeters. So only this much gain was given. So whether this treatment was unnecessary, this is something which you need to understand. Second case, 14-year-old boy with idiopathic short stature, bone age 14 years, Letrozole was given 2.5. Now we'll talk about this, how aromatase inhibitors had become the big news regarding short stature management. In this case, it was given at that point of time, came with acne and high testosterone, and parents were really concerned about that. So again, whether this was an appropriate treatment or not. So basically, HPG axis modulation is basically something which we need to really balance. It is done in disease like pubertal disorders and health like growth disorders. So we'll just see what is the current evidence of various agents that we use and how do they respond in terms of treatment. So the targets are, we all know that from the hypothalamus is mainly controlled by Kisspeptin, acting via the Kiss1 receptor. This is the stimulatory pathway. Which is the major inhibitory pathway? Anybody? It's the GABA and the MKRN3. And once you have decrease of this, we have GnRH secretion, which acts on the pituitary to release the FSH and LH, which then stimulate the testis and ovary to produce testosterone. And testosterone can either be converted to DHT, this we discussed, and or converted into aromatase via estradiol, which is the major regulator of bone fusion. So I think in this context, which all of us know, we will see where various agents will work. So now what all can be done? So now agents can work at the level of delayed puberty. So theoretically, what all can be done for delayed puberty? You just list from the beginning. So Kisspeptin, what can we do? Stimulate the Kisspeptin. So if we have an analog of Kisspeptin, GnRH, we can give GnRH, which is pulsatile, because if you give continuous GnRH, it will cause suppression of the HPG axis. You can give gonadotrophins, and of course you can give testosterone, which is obviously very simple, which we won't discuss. For early puberty, what can you do? You can use a Kisspeptin receptor antagonist. You can think of using a MRKN agonist so that you will suppress puberty. Theoretically, these are all theoretical, we'll see what are practical. You can use a GnRH analog per se, which will cause continuous stimulation and then suppression, or you can use a GnRH antagonist to suppress that. Now, if you go lower down the order, you can use a selective estrogen receptor modulator to block the estrogen effect, or use a ER receptor antagonist to block this. This is not something which is routinely used, but we'll discuss about this importantly. Or you can actually block the production of estrogen to cause aromatase inhibitors will be used in this situation. Or finally, anti-androgen. So now we'll go one by one. So which diseases do we modify? For delayed puberty, we thought about these agents which can be used, and we'll see. So there are some studies which are now showing that Kisspeptin analogs may be the way towards future management of treatment. Now, of course, they will work only if the problem is at the level of hypothalamus or genetic level. If it's a pituitary problem, they will not work. So in isolated deficiency, they will work, but not in a MPHD setting in that situation. Second big issue is the use of gonadotrophins in the management of hypogonadotropic hypogonadism, which was discussed in the crosstalk with Dr. Yuthika and Riddhi, where they talked about that. So this is how you treat a patient with congenital GnRH deficiency. So we know that in the neonatal and the infantile period, there is a mini puberty. So in that case, if somebody has a small phallic size after that period, so if somebody comes to you with micropenis at birth, maybe you do not need to give testosterone immediately. Wait for a few months, unless it is a severely micropenis. If you have ruled out all other causes, wait. Once you see that after 6 months he is not showing any increase in penile size, then you can give a short course of testosterone. Then after around pubertal age group, what age do you like to induce puberty in this group? 14 years, 13 years. And the other option is that you can actually induce using HCG or FSH. Now there are different guidelines which are coming that maybe at around 12 years of age you should start inducing with the help of HCG, and there are Japanese guidelines and we'll discuss about that very briefly. And finally for fertility you can use HCG and FSH. So now this has been shown that gonadotropin therapy is effective in increasing testicular volume. When you give testosterone, the testicular volume will never increase. It will also result in fertility. And pubertal dose is HCG at 1500 international units bi-weekly. So you start at a lower dose and then you gradually build up. There are very good Japanese guidelines on this regards. And FSH can be started at 75 units bi-weekly. Now many patients may come to you who have an acquired cause of gonadotropin deficiency, maybe in the setting of a CNS lesion or something. In that case, if you just give HCG, you may get a response. But when you talk about Kalaman syndrome, you have to use both LH as well as FSH, otherwise you will not respond. So basically all cases that we see will require a combination of both LH and FSH in this situation. For fertility you need much higher doses, HCG 2000 units bi-weekly and FSH 150 units bi-weekly. So these are very easily available. There are also recombinant forms which are also available, but they are much more expensive. So in our experience, if you use simple HuCog or HuMog, they do pretty well. We have at least, I think, 15 young men who presented with hypogonadism, Kalaman syndrome, who became fertile. How much time does it take? At least 6 months. You won't see any response in the sperm counts till around 3 months. 6 months you will see immature cells. By around 9 to 12 months you will start seeing the sperm count increase, and then suddenly the levels will increase and they will become fertile. So 80% possibility of fertility is there in a male who has isolated hypogonadotropic hypogonadism with the treatment of LH and FSH. So it's a good therapy. You should always tell them from the beginning. Now whether you treat them in puberty with HCG is another question. Because now studies show that if you give them testosterone at that time, you may damage the testis actually. So this is an issue. So many people say that if you know this is Kalaman syndrome, if somebody presents with delayed puberty and micropenis, anosmia, very small testes which are soft, you know it is Kalaman syndrome, maybe counsel them that given gonadotropin may be better at this stage because that will increase the testicular size. This is the time where cells will be sensitized and later response will be better in this situation. So it is always better to differentiate whether it is CDGP versus HH, and if it is strong possibility of HH, think of HCG rather than testosterone. This will be one big message I would like to give at this point. And there are studies, this is only done mainly in China, a lot of studies are coming from there, that pulsatile GnRH are more effective as compared to HCG, because in most cases it is GnRH deficiency. It's not the LH deficiency or FSH deficiency, it's the hypothalamic lesion. So this is good, but this is not available. You need to have a pump for that. Now what about central precocious puberty? The commonest situation in which we do the modulation. So what we can do? We can use a Kisspeptin receptor antagonist basically, but this is something which is experimental. You can use a MRKN agonist, experimental. Most common is of course GnRH analog. So when to use, which to use, how long to use, and how do you get a result out of it. So, and then antagonist, this is not much to use. I was in fact a part of this consensus guideline, and this is going to come up in this year in hormone research on the use of GnRH analog in children, and I specifically evaluated the role in terms of monitoring and how the response to therapy is. So this guideline very clearly says, not much different from earlier evidence, that it should be treated for central precocity and secondary CPP, not for any other reason. They say not for idiopathic short stature, not for any other condition. So they say it has to be CPP, whether it is primary or secondary. And the oxological indication is that if the onset is before 6 years of age and between 6 to 8 years of age, if there is height compromise as reflected by a bone age which is more than 2 years, high standard deviation for bone age less than -2, and predicted adult height 2 standard deviations below the parental expectation. So basically less than 6 treat everybody, 6 to 8 check for height and how much height is compromised. Of course, if somebody is not mature enough to have development at this age, you may think of treatment. There was a discussion as to whether we need to treat early puberty and not precocious puberty. Those beyond 9 years or 10 years, somebody comes to us, and which is a very common presentation to us. The general consensus was that there is not much benefit, as we saw in the first case, But we need to discuss with the family that we have to look at the overall circumstance and then decide. So problem with us is that we are getting very late presentations with menarche happening by around 9.5, 10 years, and that time there is too little time. But maybe we should discuss with them in detail that this is the evidence, whether you want to continue, you want to delay, we need to consider that. The other issue we'll discuss about the preparations, and we all use Leuprolide and triptorelin predominantly. So how many of you use Leuprolide and triptorelin? Yes. So triptorelin is clearly more potent compared to Leuprolide, but whether that potency gives us benefit or not is a questionable thing altogether. So there are also preparations like goserelin and historyline. Historyline is not there in India, it is in the US. Once a year implant, you just plant it here and then you get a response. So now what we need to know is, first of all, whether a 3-monthly injection is good enough. A lot of people when it came out said that 4 weekly is essential, 3 monthly is not good enough. Second was the dose. So people said that you need to give not 3.75 milligram, but you need to give 7.5 milligrams every monthly to get a response. But studies have shown that 3 monthly injection is pretty good as compared to a monthly injection. So only if you do not get a suppression, maybe then you think of it, but otherwise 3 monthly is good enough. That is one thing which is very clear for Leuprolide. The second thing they found was that if you give 30 milligrams, so 30 milligrams is a very high dose, and what we're talking about is 22.5. 22.5 is also a high dose. What do we give usually is 11.25. So what they found, that if you look at the actual LH level, maybe if you look at by very sensitive assays, if you use 30, it will be very low. So maybe 0.1. If you use 22.5, it will be 0.4. If you use 11.25, it will be 0.8. It will be different statistically, but is it clinically significant? The aim of treatment is to keep LH level which is below how much? GnRH stimulated LH level? Below 2. So 2 is the cutoff, and some people even use 4 as a cutoff. So even if it is 0.1, 0.2, 0.4, doesn't make a difference. You are increasing the cost dramatically in this situation, and you are not getting much benefit. So it is not going to result in clinical benefit. So even if you use 11.25, in most cases it is good enough, unless the weight is more than 30 or 35. So if somebody is beyond that weight, you might need to use double the dose. The good idea is to monitor. So you give that dose and see what is happening after 3 months. Now the next issue is the dose. So 300 microgram per kg, 4 weekly 3.75, above 30 kg 7.5, which becomes 22.5. Dose 12 weekly, as discussed according to that. Now the next issue is, how do we monitor? This I think I'm not putting up here, but it's very important because that was my work to do. And what came out is that biochemical monitoring is not essential and it is not reliable. If you check now and if you check after a day, the results will be bad. So we talk about GnRH agonist levels more less than 2, less than 4, but what they see is that if you do the samples, after some time the levels will be very different. So what they say, like CAH monitoring is mainly clinical. If the growth velocity is less, if the breast have become softer, if the bone age advancement is coming down, then it is fine. Do not go by numbers, don't treat the numbers. If in doubt, then you do a GnRH agonist level, because they did a very good study with historyline in which LH was high, but still the bone age was not progressing. So what they were saying is that because there is so much variation that we talked yesterday, you cannot rely on a particular level. So clinical is number one. So don't go just by numbers, and don't need to do with every injection, because I remember I saw a patient managed with the army team and they were doing 4 weekly decapeptyl, and then the LH was slightly high. They made it 3 weekly, 2 weekly, and again the LH was high. So we don't need to just go on aggressively. If the child is fine, clinical marker most important, breast will become soft, that is the first thing. Pubic hair will progress, that is different, because that is a different thing altogether. Bone age should be stable, and other parameters will really tell you. And they conclude that there is improvement, and if you use 1 monthly or 3 monthly triptorelin also, not major difference. Historyline as an agent, as I said in the US, quite effective in this situation. Now the other issue is with regards to the use of GnRH antagonist. So why do we need GnRH antagonist? Is when you give GnRH analog, you may have a flare response. So your levels may increase and there may be vaginal bleeding. How many of you use progesterone routinely? Because many people used to use that, okay, there may be a vaginal bleeding, let's give a progesterone as a prophylactic. That is not recommended routinely, and even if you give it, you may have a withdrawal bleeding. So we do not do that. We say that there is a chance, if somebody is breast stage 4, maybe 20-30% chance that there may be one withdrawal bleeding. Don't use the term menarche, this is a withdrawal bleeding, and this will happen anyway. If you don't give treatment, they will have a withdrawal bleeding. So this study looked into the role of antagonist treatment, and they found some changes, but not of any benefit overall. So there is no role of GnRH antagonists. They are available in IVF, they are using it, but not for precocious puberty. So GnRH analog remain the treatment of choice for central precocious puberty. Now, what about Kisspeptin antagonists? Again, studies are going on. This may happen. This is what Hemchand was talking. So, in future we will have these things happening later on. But still, GnRH analog is the main. What about MAS? And I think this is a rare situation. But what can we do? We can't give GnRH analog. We can modulate the estrogen receptor. So, either we use the SUM, or we use a estrogen receptor antagonist, or an aromatase inhibitor. So how many of you have seen cases of McCune Albright? And what agents have you used? Tamoxifen or Letrozole? So basically what happens is that Letrozole treatment is very ineffective. It has not been shown to improve the course of the disease because you need zero production, and Letrozole cannot make it zero. This is very important because your some aromatase will be there, so it will progress despite that. Tamoxifen is better than Letrozole, but it can cause large ovarian cysts because it causes blockage of the FSH. FSH will stimulate and you will have a large ovarian cyst. So it is a suboptimal but a good option available. Best option to treat is fulvestrant, which is a GnRH antagonist. It is given as an intramuscular injection and they result in better control in terms of bleeding and growth. So if you have refractory MAS who is having frequent period, think of ER antagonist, that is the best agent. It is used for breast cancer, so it is available. It won't be a difficulty obtaining it. Now the next issue is testotoxicosis. It's a very rare condition, just like MAS, autonomic increase in terms of the LH receptor. So what do you do here is use an anti-androgen along with the aromatase inhibitor. So this is a combination you will use. And so similar picture, so this is the McCune Albright, we talked about that. This is about boy with McCune Albright, again similar treatment was done. So we have talked about treatment in disease. So we talked about delayed puberty, think of gonadotropin early. That was one message. Early puberty, central, only GnRH analog. Next was that ER antagonists are the best as far as the peripheral precocious puberty in girls is concerned. Now coming on to health. Why would you modify HPG axis in health? Is because you want to increase growth. There is a theoretical thing that if you delay puberty, you will remain tall. So what are the 3 strategies you can think of in this regards, which will increase duration of growth? So you can from the top, you can use the GnRH analog. And I'm talking mainly about boys in this situation, because in girls you can only think of GnRH analog, you won't be using other agents. So if you use the GnRH analog, what will happen to testosterone? Low, estradiol will be low. So now people say if you have low testosterone, that will have adverse effects. So why do you want to do it in puberty? Next, you can use aromatase inhibitors. What will happen with aromatase inhibitors? Testosterone will go up and estradiol will be low. So people are very happy. There is no problem. Let the estradiol be low. I'll talk why that can be dangerous. And finally, if you use an ER antagonist, you will have everything normal and probably you won't have much. They will have selective effect only on the growth plate. But you need that ER antagonist which acts only on the growth plate, but not on bone, not on testis, not on adipose tissue. I'll talk about that a bit later. So this all came, this is a very interesting study which shows that if you give GnRH analog and growth hormone, you hardly have an increase of 2 centimeters in terms of final height outcome, and you are spending lakhs of rupees. So key message, if somebody comes too late to you at 13 and a half, 14 years bone age, you can clearly say that, okay, we cannot do much, it will be a waste, because then it will be worse for you when they will say, we have done so much and still no gain has happened. It is better to say that in the beginning, and then this becomes difficult. The next issue is, this is the consensus statement which clearly says that there is no role of GnRH analogs in children other than central precocious puberty. I think that's the end of the story. A lot of people use it, but it is very clearly mentioned in this situation. The other issue is why we would think of aromatase inhibitor treatment, and this came from these articles which came in journals around 20 years ago now, which showed males who had normal pubertal development, open epiphysis, still growing. So that showed that estrogen is the major modulator of growth, and it is not testosterone, it is the estrogen. So people thought, let's block the estrogen production and you will have improvement, and they started using it for CDGP, for ISS, and for other forms of this thing. So now aromatase inhibitors, there are studies which show that there is no improvement in terms of response to aromatase inhibitors in boys, and overall the consensus is it is an experimental therapy and it should not be done. And now if you look at it, we did actually, this is our study in Melbourne, which we developed a rat model to look for the similar picture, and we treated these rats in the peripubertal age with letrozole. And what we found that these rats in adulthood had lower bone strength and prostatic hyperplasia, because estrogen is not doing nothing in boys. Estrogen is actually helping their bones to grow, estrogen is helping their metabolism and also reproductive health. So if you have an aromatase knockout mice, it is infertile and osteoporotic. This was known. So we proved in this model also. And now even studies show that if you use aromatase inhibitor, the vertebrae are damaged. So somehow now the aromatase inhibitor use has come down, and we are very happy because we have a lot of concern in unnecessarily interfering with physiology in this regard. So final learning points are that there is definite role of gonadotropins in HH. GnRH analog is the only treatment for CPP, ER antagonists for MAS, and no role of aromatase inhibitors. I think these are the 4 key messages I like to give you at that point, and I have to end at that. And thank you everybody for patient hearing. Many of these patients that I am talking about, HH, had received testosterone for a long time earlier. The only concern is if you give in the initial phase, that is the time when the testis is developing and maybe maturing, then giving testosterone may be effective at a high dose. So now coming to your point, it is not like chemotherapy that your testis will go. So I don't think we should be storing sperms at that point of time, and they will not have any sperms anyway. Because they are delayed puberty.
Inducing storing and then putting them on testosterone.
Okay, that will be something, but in my experience, because when I say 15-20 cases, they have already received testosterone for a long time. So many of these patients were on treatment, then we started them on LHFSS, they responded well. But if you of course have a newly diagnosed, I will prefer to put on HCG, but it is not a universal phenomenon.
For some time you would
Yes.
put them on HCG.
Yes.
What would be your suggestion of the protocol?
So I would suggest that the first 2 years it will be better to treat them with HCG, so that the testicular volume increases a bit, then they respond better subsequently.
Any role of oral testosterone in this case?
Oral testosterone is very ineffective in terms of inducing puberty because it is not good in terms of potency, so injectable are the best preparation.
Visit our website learning.growsociety.in, the go-to place for pediatric endocrinology learning. Happy learning.